contraception and perimenopause. So I know what you're thinking. Birth control and menopause, that makes no sense. And it doesn't. But also perimenopause, what is that and isn't menopause enough? And I know the second thing you're thinking, who is this young lady? She hasn't been through menopause. And you're not wrong. I haven't. But what I can tell you is that when I signed up to be an OBGYN, I was passionate about taking care of women across their lifetime, and that includes your teenagers and starting their first birth control. That includes your daughters and your granddaughters in their first pregnancy. That includes women in their 40s and 50s getting hysterectomies, and that includes women in their menopausal years. It's a huge honor for me to be able to improve the quality of life of a woman who's already changed our world. So it's something I'm very passionate about and have taken a focus on in my practice. So that's what we're going to talk about tonight. So the first question is, what is menopause? It's a really, really simple answer. It's 1 year without periods. It is absolutely not a lab value alone. That's one of the most common things a menopausal woman or perimenopausal woman will do when they come to me for an annual exam is ask to get their hormones checked. And there's really very little value in doing that, as it doesn't tell us how close you are to menopause, and it doesn't predict when that will occur. For most women, the average age of menopause is around 51 to 52. And that can be earlier if you have a history of smoking or certain medical problems. And it also can be earlier with certain autoimmune conditions or depending on your genetics. I tell women that knowing when your mom went through menopause is actually more accurate than any lab value I will get. It cannot be determined accurately if you're on hormonal medicines or if you have health problems that affect your periods. So something that I experience frequently is as long as you're having periods, you can get pregnant. So we have women in their 40s and 50s who are on some sort of contraceptive. And if the contraceptive is anything other than the Paragard, which is the copper IUD, that will affect your periods. And therefore I can't determine if you're in menopause, even with a lab, without stopping that birth control. So lots of times what we'll do is we'll trial off a birth control, check labs 2 to 4 months later, and then get an idea if we think you're in menopause or not. But the really simple answer is it's when you have had 12 months without periods. And that's a really, really important kind of timeline as far as medically speaking, because bleeding patterns that happen before and after menopause mean very different things to an OBGYN if you've had menopause or not. And the therapies we can offer you to improve your symptoms, to improve your bleeding are very different. So what is perimenopause? That's the time surrounding menopause. And that's really important because the symptoms that are affecting your quality of life occur both before and after menopause. And that's not a couple of months, that's about 5 to 10 years of a woman's lifetime. So if we can control or improve those symptoms and improve your ability to succeed in your career and your family life and your relationships, that's a really important thing to do. So this is a graph that's a little bit busy. Let's see if I can use this laser. This arrow is showing the final menstrual period. And you can see that there's about 4.5 years in this area where you're having variable cycle length. So what that means is that your periods can be irregular. Classically, they get closer together and heavier. So I tell people it's gonna get worse before it gets better. And that happens for several years of a woman's life. The other thing that people classically associate with menopause is temperature sensitivity. And I specifically did not put hot flashes because many women describe their temperature sensitivity actually as cold flashes. And that's very true. They can be a sensation of hot, and they also can be a sensation of cold, and we'll talk about why that is in just a minute. And like I mentioned earlier, the time frame and whether you're in this early period, a couple years before your final menstrual period where you're having irregular periods, or you're after that year without periods, is very important because that determines both what we can offer you and also your risk of those medications. So before I could ever offer you treatment for symptoms you're experiencing, the first thing to determine is if you are here or not. Midlife changes that a woman can experience are variable, but most women, about 75%, are going to experience hot flashes. And those can be extremely disruptive, affecting sleep, affecting your ability to exercise, which affects a woman's ability to lose weight. So this is a time that people gain weight because their quality of life is poor. Irregular periods, and that happens to about 90% of people. Every now and then I get my token woman who comes in and said, one day it was just done. and they had no symptoms, and they had no irregularity, and their periods didn't get heavier, and that's lovely. But most often, periods will get closer together, heavier, before they stop. Urinary urgency and frequency. So when your estrogen levels go down after menopause, the tissue that makes up both the urethra, the bladder, and the vagina come from the same kind of source from when we developed when we were a baby. And so they all respond to estrogen, and so the collagen type actually changes after menopause, and therefore your symptoms and how you experience the sense of urge to go to the bathroom, or experience the need to get to the bathroom, how quick you need to go, changes because the tissue type is actually different. Vaginal dryness, for the exact same reason. The vaginal tissue gets thinner, it's not as stretchy. When I look at it, what I can see is that it's white, it's not as wrinkly. It can even bleed sometimes just with touching in very severe cases. And because of this, I tell people that it's one of those things that if you don't use it, you may lose it. The vaginal tissue in menopause continues to become more kind of restricted, or a stricture can develop in postmenopausal vaginal tissue because of that low estrogen state. And recurrent UTIs is also common, and that's because the urethra was really thick and strong and bulky and kind of was squeezing shut prior to menopause, and as that estrogen is lower, it can become open, which allows backflow of bacteria. And I put these last few things in a different category because all of these are very common complaints or concerns that we can address with hormonal therapy. These are not primary indications for hormonal therapy. So weight gain, while hormonal therapy may slow weight gain, it won't help you lose it. Now, what I tell people is that is if we consider treating your situation with hormone therapy for weight loss alone. However, if I improve your quality of life and you're sleeping and you're not up 10 times a night and you feel better, you are more likely to exercise. So I think that while hormone therapy is not used for weight loss in specific, it might improve your quality of life so that you can lose that weight. Weight redistribution is another major issue that we encounter in this time period, and that's because before menopause, the estrogen is higher than the testosterone, and as estrogen drops, it's not necessarily that testosterone is higher, but it doesn't have the estrogen to combat it, and so that testosterone level starts to kind of outweigh the estrogen benefits. And so people will have rogue hairs, they'll have thicker hair on the face and then thinner hair on the head, kind of male pattern things that you see start to happen in women in this time period. And all of these may or may not warrant treatment. These are all, I speak the truth, my friends.
No, we just all are like,
yes, exactly. Let's all go home. I know exactly. Everyone's gonna turn their light on really bright tonight here.
Well, I already have one bright with a magnifier.
Exactly. Now, these, other than recurrent UTIs, these may or may not warrant treatment. It depends on if it's affecting your quality of life. Many women, these symptoms can be very severe, but not necessarily are these problems. So if these things have happened to you or are happening and they're not significantly affecting you, I would say, well, then hormone therapy isn't required because there's risks to it. But if it's significantly affecting your quality of life, then treatment is warranted. For hot flashes, what happens in menopause is that the thermoneutral zone in the brain, so what our brains perceive as a comfortable temperature changes, it becomes more narrow. So we are more likely to feel hot, and then once our body starts to cool itself down, we're more likely to feel cold at temperatures that other people in the room are comfortable at. Classic hot flash is a sudden sensation of heat that starts in the core and lasts about 1 to 5 minutes. Now, the experience is much longer than that because the skin temperature takes up to 30 minutes to normalize after that. So what happens is when our body is sensing, even though we're not technically too warm, when our body senses that we're too warm because our thermal neutral zone is so narrow, our vessels near the skin dilate to cool us down. And so we start to sweat, and then guess what? Your body drops temperature and you're suddenly outside of that thermoneutral zone on the other end and you're feeling really cold. And so depending on the type of woman and their environment and lots of factors, they may be more sensitive to the hot end of that or the cold end of that. So I don't call them hot flashes, I just talk about temperature sensitivity. Now, the hot flashes may be most intense prior to your final period or the first 2 years after. So it's important to know that when we think of menopause, we think of it as an event, but really it's a transition period of 5 to 10 years where people can be experiencing these symptoms. Things you can do to modify that, of course, are changing the temperature in your environment, avoiding hot drinks or spicy foods. And people ask me what spicy foods are a lot, and we're talking about things like really hot with peppers and things like that, using things like cardamom, thyme, parsley. That's actually helpful rather than harmful. So it doesn't mean eat bland food, but the classic spicy food can be problematic. Stress, weight, cigarette smoking is a big one because cigarette smoking also narrows your thermoneutral zone. So I'll have menopausal women that will quit smoking and then their hot flashes go away. So if I don't have to put someone on hormone therapy, I don't want to. It's only if we've tried these things and they don't work. And alcohol is a big one. Some people will tell me, well, only if I have a glass of wine with dinner is my next day really bad. The next category that women experience is irregular periods, and we said 90% of women are going to experience this before their final period. And that's why so many women in their 40s and 50s get hysterectomies. It's because they're going through this time period where their brain is telling their ovaries, hey, you were supposed to release an egg, you were supposed to release an egg. And the ovary says, well, I don't have a lot left. And so you'll irregularly release eggs, which means your periods come irregularly. And when women are in their 40s and they say, I'm already done childbearing, to heck with this. And so that's how we end up, for women in their 40s, ending up with hysterectomies during this time period. It's really important to know that you can still get pregnant even if you're having irregular periods. Unintended pregnancy rates are highest in teenage years and in the 40s. So that's a really important thing to distinguish. I love this smile here.
I don't do that.
Yeah.
I'm not in my 40s, I didn't get pregnant in my teens.
There you go.
I'm just saying, your head is when you're 40, so you might not want to have one.
Exactly. But the important thing to note is that you can still get pregnant. So if you're sexually active, contraception is needed. And that's what what we're getting to tonight, is that contraception to treat your symptoms of menopause and also to prevent pregnancy is useful. The medical history, not your age, determines if a woman can still be using contraceptives. So I'll get a lot of referrals from primary care doctors that say, okay, this woman's 48, she has to come off her birth control pill, right? And that's not true really at all. Women can continue up to age 55 even with a birth control pill, as long as their medical comorbidities such as high blood pressure and so forth permit. Importantly, bleeding after menopause is never normal. If you ever have bleeding after menopause, that could indicate that you are at higher risk for endometrial hyperplasia or cancer, and that should always be evaluated. Now, the truth is the most common cause of bleeding after menopause is just atrophy, which is that vaginal wall thinning. And when that vaginal wall is thin, what I tell women is that it's like two pieces of sandpaper that rub against one another and it bleeds. So that's the most common cause, but if you ever have bleeding after menopause, it should be evaluated. In regards to contraceptives, when I say this term, what I'm talking about are a wide variety of things: pills, patches, rings, implants that go in the uterus, the IUD, or implants that go in the arm. A birth control pill actually has a higher dose of hormones than hormone replacement therapy. So I'll have women who come to me who are on a birth control pill and they're having menopausal symptoms, and they tell me, I want to go on to hormone replacement therapy. And I tell them, you are on hormone replacement therapy. So a birth control pill is actually a higher dose of hormones, the exact same ones that I would give to a woman through a patch or a pill in classic hormone therapy delivery methods. A birth control pill is higher, therefore it prevents ovulation and it prevents pregnancy. So if a woman's still having periods, she would need hormone replacement therapy in the form of a birth control pill rather than a patch or a hormone replacement pill. Lots of times what I'll have women experience is they'll be seeing a primary care doctor who doesn't kind of deal with these things day in, day out, and what will happen is they'll be taken off their birth control pill because they were in their mid to late 40s. And it's true that as you age, your risk of blood clot and stroke, things that estrogen increase your risk of, goes up. But what they'll do is they'll be taken off their birth control pill and be put on hormone replacement therapy and be having these terrible symptoms. And so birth control pills will very, very often help your symptoms more than hormone replacement therapy, a patch or a pill will do. In regards to what's right for you, as far as hormone replacement therapy goes, we used to be trained that checking your hormones and treating hormone levels was the approach we should be taking. And coming recently out of training, that's no longer what the data shows. The data shows that we should be treating symptoms, not lab values, and that treating lab values results in poor outcomes. We don't reach a woman's goals, and that's what we're here to do.
Excuse me. National experience.
Of course.
I'm 73. I'm gonna be through it all.
There you go. Yes.
Congratulations.
Exactly. I think she deserves a round of applause.
Exactly, you made it.
Thank God.
So in regards for what might be right for you, the first question I would ask is, have you had more than 12 months without periods? And if we couldn't answer that question, that's the first thing we would do. The second question is, do you have other medical conditions like blood pressure problems, issues with weight, or a history of a clot? And the third question are, what are your symptoms, and will hormone replacement therapy help that or not? And the fourth question I ask is, do we need pregnancy prevention? Again, if you've not had more than 12 months without periods and you're sexually active, the answer is yes. And the way we deliver hormone replacement therapy might be through a vaginal cream, it might be a pill, it might be a patch. There's a ring that we can actually insert into the top of the vagina so you don't have to deal with it, that we can use as well. Some hormones may increase the risk of clot, that's commonly estrogen, and some may increase the risk of breast cancer. We used to think that was estrogen, but we now know that to be progesterone. And so some women, when we use hormone replacement therapy, don't need the progesterone, and so there are hormone replacement therapy options that do not increase the risk of breast cancer. So for many women, they've been avoiding seeing an OBGYN because they say, look, given that breast cancer occurs in 1 out of 8 women, most people say there's someone in my family who's had breast cancer, therefore I want to avoid hormone replacement therapy. And there are more hormone replacement therapy options that with certain duration of use do not increase the risk of breast cancer. I want to thank you. We've talked a lot about the difficult things that women experience in menopause, but I want to remind you that do not regret growing older. It's a privilege denied to many, and I hope I've empowered you to talk to your doctors about any symptoms that are affecting you. I have to admit that I'm a cat person, not a dog person. This is a cat that I took from my farm. I grew up in Iowa on a small farm, and I've been nursing this one back to health. If you have family members or if any of these things personally affect you, these are areas that I focus on. Any questions? Thank you.